Hi, good afternoon, everyone. I'm Peter Harris. I'm President and CEO of FloSpine, and we are very happy today to have Dr. Louis Raso with us. Louis Raso comes to us from Jupiter. He's at the Raso Pain Clinic.
Correct.
And welcome. Thanks for coming.
Thank you so much, Peter.
Thank you. So, Dr. Raso, tell us a little bit about your stuff. I know you obviously went to med school, and where did you go to school, and how did you become a pain physician?
So I graduated Rutgers Medical School in 1985, and then I did a year of surgery, and then I did an anesthesia residency, and then a pain fellowship.
Okay.
And I think the surgical training has really helped me for procedures like the KeyLift.
Right.
I always wanted to be a doctor. I've never thought of anything else, and it all started because I had an uncle who was a family practitioner. And he used to come over to the house sometimes on a Saturday morning, sneak me out of the house, make me go with him on rounds.
Right.
And then he actually would let me go with the office, sit with him in his office.
Oh, that's cool.
And then he taught me basically bedside manner. And
Okay,
he said,
great.
you might have a waiting room full of people and they would be upset because they waited for you for an hour.
Right.
He said, but even if you only have 5 minutes with them, look them in the eye, put your hand on their shoulder, tell them you know what's going on, and take the best care of you can.
Yeah,
and
absolutely.
that's what bedside manner is.
Yeah, absolutely. Taking care of your patients and showing that you care.
Correct.
And so you went to med school, and obviously you're training. You undergraduate, full med school like any other surgeon, and then you did your fellowship. Your fellowship was in interventional pain? Or?
It was.
Okay, so yeah, that's great. So that's a lot of studying you did.
But it was also, it was very early in interventional, the history of interventional pain. So we did a lot of procedures then that we don't do anymore. We do much more under fluoroscopic guidance, CT guidance, all types of procedures. And now we're doing obviously more invasive, actually minimally invasive spine surgery. And that's how interventional pain is different. I sort of took the bull by the horns. In 2007, there was a device called an X-stop.
Okay.
And I was the only pain physician in the country to ever do an X-stop for many years. So I sort of was a pioneer, but also it was difficult because I had to still relate to the spine surgeons, and they were upset that I was doing those. But I really thought at that time that was the future of interventional pain.
Right. And as we know, you started your own pain clinic, the Raso Pain Center, correct?
Correct.
How long ago have you
Well, when I first came, I was part of an anesthesia group.
Okay.
But then, they hired me to start a pain center. So I started a pain center in 1990.
Oh, wow. Okay, that's quite a while.
In Palm Beach Gardens.
Okay.
And then I left the group somewhere around 2000 and went on my own. I've been in solo practice since 2000, so that's 22 years.
Oh, wow. Okay.
And I love being in solo practice because, you sort of get to control your own destiny and make decisions without anybody from above dictating
some CEO
procedures.
of a hospital. Right.
Correct.
Yeah, exactly. Now, especially after COVID, a lot of people, we had our hospitals closed down. A lot of people, didn't want to go into hospitals anymore. So I think we've seen a shift of people going from, a hospital into, ASCs, surgery centers. And we're seeing more and more procedures are starting to be done in surgery centers as well. What is your experience, and have you seen an uptick in more people kind of wanting to rather do an outpatient basis compared to doing an overnight stay in the hospital?
Well, COVID came along, and it actually was good for my practice because there are a lot of pain practices that were hospital-based. So patients didn't want to go to the hospital. They couldn't go to the hospital. So their primary care physician said, well, I'll send them to Raso because he's totally outpatient. So, but the trend for outpatient was already beginning prior to COVID. It did speed up afterwards. So now we have procedures like total knee replacements, total hip replacements, cervical fusion, big lumbar fusions with hardware, multiple levels being done in a surgery center. If there's any concerns, they send them home with a specialized nurse that watches them for the first 24 hours, any kind of bleeding tendency, anything like that. And so the big trend is less and less patients are actually going to the hospital. The only ones that are truly having hospital-based surgery are ones that were already hospitalized, and they were hospitalized to make the diagnosis and then the proper treatment. So you'll still see patients with back surgeries being performed in a hospital, but they were admitted to the hospital to try to come up with the proper diagnosis and work. So everybody has a journey coming to this day. And so, my journey was starting in private practice, building it, expanding new procedures. How did you come to be president of
FloSpine, right. So I've been in the medical device industry in spine for over 22 years. I started with a company in Southern California called Interpol Cross. I'm an engineer by background. I started as a regular engineer, kind of worked my way up. And interestingly, as we know in the medical device world, there's so many mergers and acquisitions. And Biomed purchased Interpol Cross back in the day for, I think it was like 250 million or something. So then I joined another startup called K2M. I moved from California to Virginia. There were 6 of us when the company started in the very beginning, and they grew after probably like 14 years. They grew to a $1.4 billion company and got sold to Stryker. I then joined a company actually down here in Boca called US Spine. They had a very interesting product called the facet gun, which was unusual at the time, and it did pretty well. And then we were bought by a company in Salt Lake City called a Medica, and I was with them for a few years, working remotely actually. So that's when I decided to start FloSpine. So we started FloSpine as a company just doing regular pedicle screws, and we just launched our cervical plates about a year ago. We have 2 products with FDA right now. We have our cervical interbody, which is a 3D printed cervical interbody. As you know, a lot of the market is now moving towards 3D printing. But the product we're very excited about is a expandable interlaminar device. It's called the KeyLift. And that's currently with the FDA, and we just waiting for approval. And it'll fit into your realm because you do a lot of interspinous spacer devices. And so we believe that this device is a lot different to what's currently on the market because it actually goes in between a lamina and can expand.
So what brought about the interest in something minimally invasive after doing classic pedicle screws and rods?
Right. So, typically we find in the industry, it's moving more towards minimally invasive procedures. So that's the direction where it's going. And then also, as we discussed earlier, a lot of these procedures are now moving into, the ASCs. So we see that as a huge market with a lot of potential. The KeyLift product has gained a lot of interest from around the country, and I believe it'll fit into the pain market very, very well compared to current product which are on the market.
So, the tough thing these days as a pain physician is being able to do these procedures.
Correct.
Without offending or at least challenging your relationship with the ortho spine surgeons and neurosurgeons. How have you navigated that with FloSpine?
Good question. We've had some surgeons who do not have a problem with having an interspinous device, and we also plan to have 2 surgeon advisory boards. One will be for our spine, and one will be for the interventional pain market as well.
Do you think that KeyLift eventually will be the type of device that even with an open spine surgery, rather than doing another level, they just add this to the adjacent level rather than adding additional hardware to those levels? Do you see that in the future?
I think so, especially if it can. What often happens, as you know, with doing a fusion. Once you do a fusion, a lot of times you have degeneration of adjacent discs. So if you could put this in and expand it and kind of prevent that disc from degenerating, give the patient, I don't know, another 5-10 years.
I know you're in the process of FDA approval, and as a physician, we hear about that.
Correct.
And we think it's a very arduous process.
Yes.
What really is entailed with getting FDA approval?
So as you mentioned, we're doing the FDA, the 510K process, and that entails looking at a current device which is on the market, which we call a substantially equivalent device, and then you got to make sure that your device is equal or better than that device in testing. So with the KeyLift, we went through all the motions which they want us to do, doing all the mechanical testing, compatibility, the biomechanical testing, as I mentioned. And so the last step we're doing, they want us to do some cadaveric spine testing. So because this device is kind of a little bit different to what's currently on the market, the FDA want us to do get actually human spines and put this device in and do flexion extension device test on the test machine and make sure that it's it's not going to come loose, and which I think is a good test to do, because from that we actually working with a lab up in Boston, a well-respected PhD doctor up there, and we're going to actually from that get a white paper, and we'll have some good results which we can give the doctors like you confidence that once you implant a new patient, it's going to be able to be stable. It's not going to migrate or move or come loose or something like that.
So if you compare the KeyLift to some of the devices that are on the market, the big question is, and I think some of the criticism from the surgical side is, it's not really a true fusion.
So yes, and as you mentioned, compared to some of these other devices, they all clamp onto the spinous process. I think that kind of goes onto the lamina, if I'm correct. But
there are some teeth that are supposedly grips the lamina with the stem.
Right, exactly, yeah. They kind of angle at 45 degrees.
But it's only once you size that occurs.
Right.
So once you do that, it's pretty much, you got about as much distraction as you're going to get. So it really depends on how well you size that.
Correct. And, the nice thing about ours, if you can, obviously clear out the interspinous ligaments and get it all the way down and get it in between the lamina, that will make it, unique, and then you can distract it in situ as well.
Right, and I think the only thing we have to really be careful with is once we train other physicians to really tell them, all right, this is the view you want to see, that you're actually getting down to the lamina.
Correct, yes.
Your device does grip the lamina, but
correct,
you want to make sure that people know exactly, I'm down right at the lamina. Should I go deeper, or am I too shallow? And that's where the training will be very important.
Right, exactly. Correct, because you want to get, if I could be wrong, but you want to get, I guess, as close to the ligament flavum as possible. And then do your distraction. Is that correct?
Right, and so you actually, when you're removing the interspinous ligament, you want to get down deep enough that you can almost see the ligamentum flavum.
Correct, yeah.
And once you do that, then you're
right.
You're right about at the lamina.
Right.
But you want to be able to tap that into place under an X-ray.
Correct.
So you want to be able to look for that spinal lamina junction, and that's what's going to be really important.
Right, and I'm sure some spine doctors out there, they'll put this in, and they probably might do a full laminectomy as well,
or at least a minor decompression.
Right. Yeah.
And some of those devices, the other devices that I mentioned, they're already doing that, where they're trying to do a decompression. I don't know if that's proper to say both at the same time. I mean, even the interventional pain physicians, we could do a decompression at the same time.
Okay, but would you take down the ligament flavum and actually?
No, you would just basically trim some of the lamina.
Okay.
Right at the base of the spinous process.
Right.
You wouldn't take the ligamentum flavum down. You wouldn't expose the epidural space,
right,
dura, anything like that. So the next thing is patient selection. So what type of patient do you see that the KeyLift is going to be key to?
Well, the indications for use are definitely mild to moderate lumbar spinal stenosis, and obviously you guys are the judge of what's mild to moderate.
Right, that's why we read our own MRIs now, because I've noticed lately that the radiologist will call something moderate, and then I'll look at the MRI myself,
right,
and I'll see it as severe, or vice versa. They'll call it severe, and I'll see it as moderate. But radiologists' view are very different. They'll call something moderate even though it is severe, because they still see a little bit of CSF at the tip.
Okay.
Right by the base of the spinous process. And they see a little bit of CSF, they say, well, if there's CSF, that's not severe.
Right.
And that's the difference. The one thing I think the KeyLift has a potential to treat a severe stenosis.
On the indications for use, it just says lumbar spinal stenosis. We don't say mild to moderate.
Okay. The other question is, with somebody with a spondylolisthesis. I think, some of the other devices I mentioned, they can treat up to a grade 2.
Okay.
Because we get flexion extension views on all those patients.
Right.
We suspect a spondylolisthesis, we get flexion extension views.
Right.
And then we look for any kind of motion. And as long as the motion isn't greater than 3 millimeters, or a grade 1 doesn't progress to a grade 2 with a flexion and extension, then I think all those devices will be good. All those are key.
Right.
So I think what I see the KeyLift is very much similar to the other devices.
Sure.
Grade 1 up to a grade 2 spine.
Okay.
And even up to severe stenosis.
Okay.
Remember, even if they have severe stenosis, if they have other comorbidities, heart disease, lung disease,
Sure.
they're on blood thinners.
Right.
These are patients that probably couldn't tolerate 4, 6, 8 hours prone under general anesthesia,
Exactly.
2 to 3 days hospitalization, higher risk of spinal fluid leak, higher risk of any kind of blood transfusion. These are patients who just want to improve their quality of life. Sometimes that quality of life is their ability to stand for a few more minutes, to walk a greater distance.
Right.
I think those are the patients we're really going to look at.
Sure.
And spinal stenosis is so prevalent not only in South Florida but nationwide.
Right. Exactly.
So most of those patients really are going to be
Right.
coming into my office on
Yeah.
a regular basis. Assuming you're going to get FDA approval soon, the next big step is growing the company, growing your sales force,
Right.
your reps, your distributors, and then training physicians. How are you going to accomplish all that growth within a short period of time?
A good question. So right now we're actually doing a campaign launch and doing a fundraising through a company called Start Engine, and basically the funds will be used to obviously finish the KeyLift development, and then, as you know, what's very important is to get the training out there. So we're going to initially start with some what do you call an alpha launch. So we're going to have 10 sets. We get some key opinion leaders like yourself, go out there, do a few cases under your belt, and then also do training around the country. And I'm sure you've had some experience in that.
I have,
Yeah.
and I can tell you, I've been involved with many companies like this where they have a new device, and
Right.
the key is, number one, the attendees are the right attendees. You don't want a rep, a distributor to recommend a doctor just because he knows him from other devices. You want somebody that's going to basically be ready to do that procedure within a few days of leaving the course, because they're going to be on a cadaver, they're going to be trained on the KeyLift, and so we want them to already have privileges at whatever facility they're already presently working at that are similar to the KeyLift. So when they leave, it's not a thing about a political thing about trying to get privileges at the facility, but also I think they have to have patients in mind when they come to the training. So it'd be ideal if they brought 1 or 2 MRIs of potential candidates for the KeyLift that they either saw in the last few weeks. They bring the MRIs, we put them up in front of the crowd, and then we pick what is the best way to treat those patients, whether it be KeyLift or do nothing for those patients.
Correct.
But also, once they leave, they have a very short-term memory for what they learned on a cadaver. So we want them to do a case with the KeyLift within 6 weeks. Otherwise, it's really going to be out of that short-term memory, and then they either need to be retrained, or then we have to find, a KOL like myself to travel there and help them with the first few cases, which is not always easy to do.
Right. And in your opinion, surgeons who obviously are put in a spinal spaces, they're used to this procedure, so for them it's not a big challenge. What about a pain? I'm talking about an interventional pain surgeon who's has never put in a spinous device before. Is that a big challenge to train them and get them used to it and up to speed?
I think the toughest thing is learning how to dissect down the side of the spinous process, down to the facets, down to the lamina.
Okay.
And be comfortable with that dissection, because if you stay right on the spinous process and do what's called the subperiosteal dissection, you avoid all the bleeding. So if you want them to learn that process, because otherwise, if you get into any muscle, then it's just annoying, like little bit of bleeding. And so, it's a very clean dissection if you stay right on the bone and do a subperiosteal dissection, even down to the facets. And then you have to teach them how to use a bone rongeur to actually remove the interspinous ligament, and then to create or decorticate the bone with your rasp, and then to prepare that for the arthrodesis.
Well, we're definitely very excited about it, and we thank you for your coming in today and for your time, and it's been a pleasure having you here. So, thanks very much.
Thank you.
Thank you.